So welcome to our Caring Connections today on January 12th, and today we're going to hear about diabetes. Caring for diabetes, reaching patients as well as our caregivers. But the first thing I'd like to do is a meditation on diabetes care and compassion. Do you not know that your body is a temple of the Holy Spirit within you, whom you have from God? That's 1 Corinthians 6, verse 19. Living with diabetes invites us into daily attentiveness, listening to our bodies, tending to our needs, and responding with wisdom and patience. Scripture reminds us that our bodies are not burdens to endure, but sacred vessels entrusted to our care. Each choice we make, checking levels, nourishing ourselves, resting when needed, is an act of stewardship, not failure. It's an interesting way to think about it. God does not ask for perfection, only faithfulness. Let us not grow weary in doing what is right, for we will reap at the end of the harvest if we do not give up. And that's Galatians 6. There may be days of frustration, fatigue, or fear. And on those days, we must remember that God walks with us in the ordinary rhythms of care, just as surely as in moments of healing and hope. Strength is found not only in numbers or outcomes, but in being perseverant. For caregivers, family members, friends, clinicians, and nurses, Scripture also speaks words of deep honor. Bear one another's burdens, and in this way you will fulfill the law of Christ. That's Galatians also. Caregiving carries much with it that's unseen. Vigilance, concern, patience, and love. Their work reflects the compassion of Christ, who noticed hunger, pain, and need. And it doesn't have to just be healthcare providers, obviously, it's all of us. And respond with mercy. Yet caregivers too must rest, for even Christ withdrew to quiet places to pray. And the last scripture reference is from Matthew 11, and that says, "Come to me, all ye who are weary and heavy laden, and I will give you rest." So we must remember that in caring with those with diabetes and in caring for ourselves as caregivers and friends, we are never alone. God's grace meets us in the daily routines and in the shared compassion that binds patients and caregivers together. And I want to share this prayer. Gracious and loving God, we come before you with humbled hearts, trusting in your constant presence and care of us. We lift before you all who live with diabetes. Grant them the wisdom in their decisions, patience in their bodies, and peace when the journey feels heavy. Strengthen them each day and remind them that they are fearfully and wonderfully made. We also pray for caregivers, those who watch closely, serve quietly, and love deeply. Renew their strength, guard their spirits, and grant them moments of rest and restoration. Let them too know that their work is seen and cherished by you. Surround both caregivers and patients with compassion, support, and hope, guiding medical professionals with skill and gentleness. And please bless every act of care with your healing presence. May your peace dwell in every body, every home, and every heart, and may we walk forward together, upheld by your grace. In your holy name we pray. When we talk about diabetes, I remember so many times when patients would say, well, I'm going to worry about that when I'm older. I don't have to worry about it now, I'm going to worry about it when I'm older. And I know most people with diabetes have learned that it's an insidious disease that it just catches up with us over time. And I can't tell you how many people, I'm sure all of us as nurses in the room have seen people who think they're getting away with it, and the diabetes will be dealt with later, and then it takes really serious effects on their health. So today I'm just really pleased to introduce Pam Grubbs. And Pam's been a clinical nurse specialist in diabetes here at the end of her career. She's worked at Mayo 36 years. And I was asking her today because she and Jody Hellickson, my colleague, and I all worked as clinical nurse specialist counterparts in different specialties, but I had never known how many other areas Pam had worked. And so she said prior to being a CNS, she worked in the float pool, and in a medical center, that takes you to every unit in the medical center except OBGYN she went to. So for many years she did that. And then when she became a clinical nurse specialist in 2005, she started doing a whole list of specialty areas, first in surgical units, ears, nose, and throat, plastics, general surgery, gynecology, and then she went to hematology and gained a lot of experience in that area. Her father became ill, and she said she went home to Austin for 3 years and worked in the Austin area, and then came back, and the last few years of her career she's been a clinical nurse specialist in diabetes care. So obviously she has a wealth of knowledge. And today Pam really wants to talk about the differences between type 1 and type 2 diabetes, describe the management of common choices of the diabetic patient, which are important to hear about, and then review components of living well with a chronic disease. I don't think many times we think of diabetes as a chronic disease, but it's one of the most chronic. And working with heart disease, I never thought of that as chronic in the beginning, but it sure is. Diseases that stay with us for our life that we have to manage and care for. So please help me welcome Pam Grubbs.
Thank you, Kathy. All right, well, I tell you, when I put this together and said tidbits, I'm talking tidbits because this is a huge, it's a huge discussion. The guidelines, even from our governing body of the American Diabetes Association, they change guidelines almost every year on us. So I'm like, okay, it's hard to keep up. But there's basics that will always be, and that's kind of what I wanted to cover here. She already told you what we're going to be discussing today. I'm going to talk about type 1 and type 2 because I don't know exactly who I'm talking to. Type 2 is like 90% of the diabetics in the world, and type 1, like I said, under 10%. And then we're going to be talking about the aspects of care, and then take a look at what it is to live with that disease. So, the whole idea behind the diabetes disease being seen is that we need to catch it early, because if you don't, then we run into complications, and those complications are microvascular and macrovascular. I'm going to talk about that later, but it's the unseen things that the diabetes is doing to the body. So that's why we're like, ooh, we got to catch it early. We want to catch it way back when it's in your chart as impaired glucose tolerance. And I remember thinking, okay, that's changed names a million times too. It used to be prediabetes. So when I was working with diabetic patients in the hospital, it was hard to find where they got the diabetes diagnosis because they were using all of these other names. So we want to catch it before it becomes diabetes, period. The small, easy changes to caloric intake and increase in exercise. And then, of course, be aware of your genetic predisposition, because some of this is genetics, so we can't fight with genetics, but it's good to be aware of it. Regular medical exams, can't talk today. And then loved ones and caregivers can help prevent complications, and I'm going to go into that also, because it's wonderful to have those people supporting you, but they're going to be looking out for, hey, did you notice, maybe your sight is getting a little bit more poor. Maybe we need to go for that yearly eye exam. Regular blood sugar monitoring, and then, of course, managing stress, which I know that Kathy can help us out with, because she's very good at all of those different programs that manage stress, whether it's healing touch or meditation, etc. Treatment is always individualized, and I don't know how many times I heard when I was working in the hospital that, oh, well, I'm diabetic, so that's a blanket statement. And I'm like, nope, everybody's different. One person might feel wonderful if their blood sugar is 200, and another person might say, wow, okay, if it's even above 120, I feel like crap. So everybody is different. Everybody's going to be on different meds in order to control that. Some people, it's just the diet. They're going to say, hey, I'd like you to do this kind of diet, limit your carbs, and make sure you have exercise. And then if we have to, we can add in a medication. And it could be just one, it could be just metformin. Be familiar with your medications and the proper use and the side effects of those. And again, I'm going to go more into that as we go through the presentation. And then be in tune with your body and your glucose awareness. Lots of patients, when I was working with them, they'd say, I had no idea my blood sugar was low. And I'm like, okay, did you feel a little sweaty or maybe all of a sudden fatigued? And they're like, yeah. And I'm like, okay, that would be one of them. So you got to be in tune with how you're feeling and what your body's telling you. And then, of course, know your resources. We are very blessed in Rochester to have wonderful resources for diabetics. We've got diabetes educators, the primary care providers. If they need assistance, they go ahead and consult endocrinology. And then, of course, the American Diabetes Association is wonderful. If you can get into their website, they've got lots of free resources. So let's go through what diabetes looks like. The type 1 diabetic, here's the causes. The autoimmune disease is what we think happens, and that was the destruction of the islet cells within the pancreas. So these patients in type 1, they don't have any insulin in their body at all, and you have to have insulin in order to live, okay? It could be idiopathic. It could have been a disease that attacked the pancreas and killed off the islet cells, or it could be surgical intervention. Patient had pancreatic cancer. We had to take the whole pancreas out. Now we've made them diabetic. They weren't diabetic to start with, now they are. The facts about this is that destruction, when it's an autoimmune disease, the destruction happens more rapid in infants and children as they're developing. So that's why they call it juvenile diabetes when you see a type 1 usually. Slower in adults. And a type 1 type 2 can turn into a type 1 as they grow older. So again, another reason to keep it under control. This person is dependent on insulin for life. Every single time I ever talk to the endocrinologist, they tell me, okay, make it very clear to whoever you're talking to that if this patient, let's say they're in the hospital and they're on the insulin drip, it can't be turned off for more than an hour without their blood sugar going sky high. So, yep, it may have dipped to the point where the nurse was like, or the doctor, I'm going to turn that off. It's going to bounce back because you have to remember where that glucose is coming from. It's being let go, released from the liver, which is storing it as we eat and get energy. It stores the excess and then releases it as we need it for energy. It's always going to be there. Type 2, this was a very cool demonstration that I saw. I think it was one of the first conferences I went to when I took over the diabetes population in the hospital. And this gentleman went ahead and drew 2 lines, and in between it, he put glucose, the word glucose, and he said, these 2 lines and that glucose represents your bloodstream. Your glucose is in the bloodstream. Over here, and then underneath that bottom line, he drew a circle. And he said, this is the cell. It actually needs to get into the cell for you to use it, okay, for you to use it and it to continue with your health. He said, now, and he wrote down insulin right next to the glucose underneath it, and he said, this is a protein that your body makes, should make, okay? Comes from those islet cells in your pancreas. He said, it goes ahead and travels down here to the cell, and it pairs with your glucose. It unlocks a door on that cell and lets the glucose in. If that door gets stuck, gets sticky, we have less insulin, or it isn't working like it should be, now we have type 2 diabetes. Because type 2 does have some kind of insulin, just doesn't have enough. And there's all kinds of reasons why. The odds are 1 in 3 that people are going to be diabetic as they age. And I think it was a huge amount. 80% of the people that are diabetic that don't know they're diabetic I sit there and go, okay, yep, I get that. That's why it's added into our physicals. As we age, all of a sudden the A1C comes in, a fasting blood glucose comes in, because they're going to be on top of this if and when it happens, because our probability is quite high. And then along with diet and exercise, again, they can add in metformin. Metformin is our first line drug. It's a wonderful drug, and I'm gonna tell you all about that. But as you can see, all of this disease increases with age and obesity. And I tell you, that's a hard one. That's a hard one, because as we age, we usually gain weight, especially as women. Women, we just get a raw deal. I just gotta say, because everything shuts down and we gain weight. It's not that we're eating more, it's not that we're less active, it's hormonal. So again, we're behind the curve here. So medications, oral medications, like I said, the purpose of those oral medications, no matter what you're put on, they all have separate things that they're doing for you, okay? So one increases the insulin release, one improves the insulin sensitivity of that cell to let it in more, and then one promotes glucose excretion from the liver. It's stimulating that liver, give me more, I need more glucose. That's a first line drug. Then if they have to, they will add in other medications. And I don't know about anybody in the room, but I think I've seen up to metformin plus 3 other oral meds before they even move on to insulin. They want to boost up whatever you normally have, that type 2 diabetic. We're gonna say, yeah, you've got a little bit of insulin, it just needs a push. Your pancreas needs a push. So then they can also go ahead and add in these SGLT2s, and I'm absolutely positive you've seen these in the commercials, okay? SGLT2s and GLP-1s, as they're called, those 2 meds have been in the news, I bet you, for maybe at least 3 years. About, oh, this is a wonderful weight loss med, okay? Now we're gonna go ahead and give you this. Again, everything has a side effect. So, so we have to take that into consideration, what we're using it for, and what the side effects of that wonderful drug are. The injectables, I put on the right side here, and again, it depends on the company that makes the injectable, okay? And why I put this up here is for the caregiver. The patient themselves, they usually know, they're very good at this. They've got it down. They know it better probably than the doctor and the nurse do, okay? But that caregiver is a second check. They're a double check for that patient, because all of these different names for the same med, as far as rapid acting, intermediate, and long acting, gets confusing. And depending on the company that makes it, it might even be a different color. You know, one might be blue, one might be orange. Lily might have both of those are blue. So again, we need that double check of that caregiver or loved one or somebody to go ahead and say, hey, you know what? I think you got the wrong insulin here. Yep, you're on 2 of them, but you gotta make sure that you're taking the rapid acting when it's ordered. And then of course the long acting at the right time, because as you can see, they all last different times, and that's when our insulin-dependent diabetics run into trouble. Because if they go ahead and they say, okay, I ate, let's say, I need to bring it down right now, I'm gonna use my rapid acting, that's gonna be the one that I'm gonna take when I eat, okay, after I eat. These other 2 are going to give, look at how long they last, 18 hours, 24 to 36 hours. That is because it has no peak. Those 2 meds don't have a peak. So they get into your bloodstream in the first couple hours, and then they stay there all day. They're supposed to keep you nice and at a steady state. They're supposed to echo what your pancreas is supposed to be doing. So here's the GLP-1s. I mentioned them briefly. Like I said, again, these are being marketed as weight loss drugs too, because they do. How they act is why they're a weight loss med. They decrease your appetite. They slow down your gut, so you aren't as, let's see, the food isn't moving through. Let's put it that way. And then you feel full, eat it earlier. So you eat less because you're like, okay, well, that mechanism that in my brain that tells me, no, I'm not full yet, I am full. Haven't eaten much, but I'm full. The GLP-1s, both of these are all, well, actually all of them, are given weekly. There are some doctors that will go ahead and give some of them, like if it's an oral form of this, you might have to take it every day, okay? But most of the time it's just weekly. Now, on to the complications that we can see with diabetes. This is the whole reason behind doing the management, why management is so important, and why I'm sure if you've been to your doctor recently, they push. Well, let's talk about, have you stopped smoking if you're a smoker? Is your blood pressure under control? Because we gotta do that too. And it's a whole bundle of stuff that they're looking for that diabetic. They're looking at their heart, their kidneys, they're looking at everything. But this is why they're trying to prevent complications or slow it down for the diabetic. So microvascular, first of all, retinopathy, and this is the eyes. The eyes, boy, we gotta protect our eyesight. We want, eye exams being done. I'm behind on my pages, sorry about this. But the worst outcome of retinopathy is blindness. So again, those exams, the eye exams, the regular eye exams are super important. Nephropathy, again, that is the number one cause of end-stage renal failure. Okay, and yeah, I think if you talk to, I don't have the statistics on this one, I was going to look it up, but the people on dialysis, I'm guessing at least half of them are probably diabetic. And it's because of that microvascular damage that's done by the diabetes on the kidneys. And then neuropathies. And again, neuropathies are usually things like, the neuropathies I've got written down here are not the peripheral ones. So the microvascular ones are like sexual dysfunction, orthostatic hypotension, which is your blood pressure falls when you stand up. Stand up too quickly, it drops. Neurogenic bladder, which means that your bladder doesn't work like it's supposed to. The bladder is a big muscle. So if we do damage to it and it doesn't work like it's supposed to, it will retain everything until it doesn't work. And then we have to go to putting a catheter in to empty it. Yeah. So again, trying to avoid that kind of damage. And then the last one is gastroparesis. Gastroparesis is food doesn't move through like it's supposed to. All of a sudden, everything stops working. So you end up feeling full all the time, nauseated, sick. You don't want to eat. So then, yeah, it's a horrible cycle, because when you don't eat, you treat your body to hang on to everything you do, or to make more of glucagon, and of course it only has so much. If you're not eating, your body isn't storing what you don't eat. See what I'm saying? It's a big circle. The microvascular damage is a lot more in the news. This is the heart attacks that are happening. Again, the cardiovascular damage that's being done by diabetes. Cerebrovascular is going to be the strokes that happen. It's also going to be this peripheral down here is going to be the foot ulcers. And again, I'm sure that if you've been to the doctor recently, they take a look at your feet, don't they? They go ahead and they say, yep, we got to look at everything. Okay, how about your feet? Are you wearing good fitting shoes? Are you making sure that you don't have any sores on here and that there's good circulation down here? So those are the kind of microvascular and macrovascular complications that we're trying to avoid, okay? This is responsible, this slide, these 6 things, are responsible for 2/3 of mortality from diabetes. This is the enemy. This is what we're trying to stay away from by teaching people how to manage their diabetes, how to live with it. So let's move on to the areas to focus. I like this slide deck. I thought it was perfect for this time of year. Anyway, and it's pretty, and we don't have to worry about, slipping on that ice. So here's the areas to focus, whether it's the diabetic themselves or their family, caregivers, whoever is taking care of them. Okay, healthy diet. And we talked about this before I even started my talk. We were talking here in the hall, and we were talking about balanced and scheduled. Okay, so we're going to try to reduce or limit the sodium, because sodium is going to be hard on the kidneys and that heart. Remember, we're trying to prevent those complications. We're going to limit the carbohydrates. Does anybody do carb counting at home? Carb counting is a wonderful thing, but it takes a lot of practice. And we always tell people when we do teach them, we're like, oh, go ahead and get a carb counter on your phone. So then you can put in, I'm eating at Wendy's. I'm going to get a Frosty. How much is that? And it's going to tell you. Again, in your medical exams, they're going to say, please stop smoking, because it narrows all of your vasculature, and we already have that problem. We already have diabetes working on those little capillaries. We're going to monitor the blood pressure, because again, as I showed you in the macrovascular complications, it does damage to the heart and all the vasculature in there, and your kidneys, which regulate your blood pressure. And then exercise regularly. We were talking about this again before I started the talk. And this doesn't have to be, oh, I go to the gym every day and I work out for an hour. This might be that app that I found on Facebook that says you can do 7 minutes of walking, even if it's in place, and just get your heart rate up and do stretches and etc. And do that every day and get a routine, regular exercise. It doesn't have to be huge, especially this time of year. I don't even know how many times I've heard in the last week people say they slipped and fell on the ice and broke something. So let's make sure that you can keep up with your exercise and do it at home. Because this is what it does for you. It improves the blood glucose control by increasing the insulin sensitivity of that cell. It's going to let more insulin into it, and it's going to lower how much you need, whether it's medication, whether it's insulin or oral medication. Self-care is huge here. Okay, foot care. I can't say enough about it. Foot care is a big deal. Make sure that your shoes fit properly and that nothing is rubbing. That you're examining your feet. If there's anything wrong with the toenails, make sure those are taken care of and there's no micro cuts or entries of any kind of infection in the nail or the foot. Regular medical checkups, because they're going to cover everything I just said. That's going to be the major part of your 20 minutes or an hour. Some of those initial appointments are a good hour, because you're talking literally to everybody. You're talking to the diabetes educator. You might be talking to the dietitian. So regular checkups are huge. Stress reduction and management. Again, huge, because every single one of the symptoms on the complications is affected by stress, whether it's stress eating, it's high blood pressure, it's hard on your whole body stresses. So stress reduction and management is huge. There are all kinds of apps on your phone or your computer that you can go ahead and take a look at for stress reduction. And it's everything from, like I said, Kathy can help us out here. Meditation, that she does so beautifully. Healing touch, Tai Chi, all of those healing, I just, there's so much out there, isn't there, Kathy, that we can do for, is Hermitage It's still open?
Yeah. I just wanted to offer one thing.
Because our nurses here at Redeemer do blood pressures, and we have about several nurses that help us. But when we do it, we were just talking about that yesterday with a parishioner, Jody and I, in that just sitting in a chair with our feet flat on the ground and taking 3 deep breaths can bring a blood pressure down 10 millimeters. People don't believe that, but it happens. So to have them do it, but there's just so many simple things that can make a difference in the course of a day.
Oh, yeah. Yep. Absolutely. Like I said, there's so many free resources that you can get like on your phone. You don't have to go anywhere. It's wonderful when you can, like I said. But it's a very big must. It's going to help everything from your blood pressure to just everyday stress. And remember the goals of diabetes management. These are the 2 highest goals, and it's going to be no matter where you see it, whether it's on the American Diabetes website, wherever. You want to prevent complications. This is the goal of what you're doing. And then to avoid or alleviate the symptoms that come with, whether it's hypoglycemia, so low blood sugar, or hyperglycemia can get you into a lot of trouble. That's going to be probably a hospitalization, so we'd rather not see that. Does everybody know the symptoms of what they're looking for? Okay, for hypoglycemia, it might look different in everybody, but the typical symptoms are going to be that you have pallor, so you're pale, you're sweaty, you have extreme hunger, you're shaky, you just don't feel good, period. Fatigue, okay. The ones for hyperglycemia look a little bit different. You still might have that weakness and the fatigue, but you're going to have maybe a fruity smell to your breath. You are going to be thirsty. You can't get enough of whatever you're drinking, okay? And in return, of course, then you're going to be going to the bathroom a lot. So you're going to be peeing a lot also because you're so thirsty. You're trying to make up for what's happening in your body because your blood sugar is so high in the bloodstream between those 2 lines. It's so high that it's throwing everything else off. It's throwing all of your electrolytes off. And because you're peeing more, you're putting out potassium. So now that very important electrolyte that everybody needs to keep their heart healthy is being peed out, okay? That's when the patients get in trouble with that high blood sugar because it's not helping them at all. It's actually throwing the whole body off, which usually is in perfect harmony until something like that happens. Oh, and then I've got questions. So, like I said, I kind of went through stuff. I went ahead and when I was talking to Kathy about what you might want to know, I kind of narrowed it down. Because like I said, diabetes is a huge subject. So I narrowed it down to what she thought everybody might want to ask. And then I kind of tweaked it. But I did talk to somebody out here in the crowd about diet. We talked a lot about diet and exercise, and then that weight gain that comes with. Some of the meds they have actually a side effect of weight gain. The injectables are the other way, that's weight loss, but it's because of what they do. They go ahead and they depress your appetite. They depress the digestion. They slow down your digestion, so that's how you lose weight. But as it's now coming out in the media a lot more, is that that's a lifelong thing. So if you start that for weight loss, you will have to be on it your whole life because you've taken normal hormones that are in your gut and you've amplified them. So now, if you don't stay on it, your body goes back to what it was, and you'll gain weight back. Not all of it probably, but you have altered what your body usually does. So that's my diatribe on that. I try not to go off on anybody, but I said it's hard. It's hard to lose weight. I've been struggling with it almost my whole life. I said, so again, those tips of the areas of focus, that's what I try to do too. Try to do that healthy diet. I know she was saying that one of the audience here was talking about the new pyramid, the new food pyramid that came out. And I sat there and went, yep, that's always been a healthy diet, more fruits and vegetables. Your carbs should be what, a third, a fourth of your plate, okay? The rest should be fruits and vegetables. Do you need grains? Yep. Do you need healthy fats? Absolutely. Your body needs all of that in balance. So it doesn't surprise me they redid the food pyramid. So, does anybody have any questions? Did I cover what you were wondering about? Because like I said, when Kathy got a hold of me to go ahead and do the talk, she says we have a lot of questions on diabetes and.
You know, I hear those commercials on the TV about Jardians or whatever, and I think, well, you know, I don't feel like I'm obese by any means, but I know that if I could lose maybe 10 or 12 pounds, that would help a lot, right? And so I think, well, maybe if I just did that for a short little bit, then everything would be great, you know, well, maybe it wouldn't be great, but knowing that you have to do that forever answers that question about, well, okay, doing that isn't gonna solve my problem.
Yep, that's a long-term thing. So if we can get into healthy habits, you know, you find a diet that works for you that you can actually live with, you know, and go ahead and treat yourself. We were talking about that earlier. You know, instead of maybe having 4 of those little Dove candies, have 2. Because if you take it totally away, you are going to binge. That's just human nature. And you set yourself up for it. I don't know if you remember back in the 80s and 90s, they had diet centers that were starvation diets. It was 500 calories a day, okay? And they said, look, all these people are losing weight. And all they did was teach their body to hold on to everything they did eat, okay? So you've taught your body that, it's not good. Let's put it that way. Your body is going to hold on to everything you do eat because now you're going to binge. So now it's going to hold on to all of that sugar that you just ate or convert it to fat, which we don't want it to do. So
Pam, I'm starting to hear a lot of about the side effects of some of these meds, and I think a lot of people aren't aware of what that's right, because we all want fast return on what we're doing to reach our goals, right?
absolutely.
But I think they have to be very careful because we are starting to see more, and they haven't been out long enough, so we're just starting to see some of them. So
Correct.
And the commercials, they make you want to do it, right?
Right. Oh, absolutely. And that's what a commercial is supposed to do. Yeah. They're supposed to tell, and in the little tiny print at the bottom of that commercial, they're going to say, and this could happen, and that does this. Okay, so the SGLT2s, good example. Both of, now that med, I'm going to talk about that med first. Wonderful med, because its side effects, just like the GLP-1, it's going to do weight loss, it's going to do a whole bunch of stuff for you. And it's because of the weight loss, it's helping out your heart failure, it's helping out your kidneys, it's helping out all of that stuff. Now, on the other side, SGLT2s, because of what they do, how they work. So how they work is they go ahead and they dump your sugar that's in your bloodstream into the urine. Okay, goes through the kidneys and out. Good. Lowers my blood sugar, lowers my A1C. When that happens, it increases your chance at having UTIs because of the sugar intake or the sugar output in that urine. Okay, and it increases your risk at having what they call euglycemic DKA. So it throws off your body without giving you a high blood sugar. Diabetic ketoacidosis, DKA, is usually a high blood sugar. It's usually real high, and then you have everything that comes with it. You have a low potassium, you're super dehydrated because you're dumping everything out. That's how the SGLT2 works. But it's not going to have a high blood sugar. It's going to have a normal one because it dumped it out in your urine, okay? But everything else that comes with diabetic ketoacidosis comes with a low potassium. Your heart needs potassium to function normally. So you're going to start, your whole body is going to start having a problem with that. So those patients come right into the ICU and everyone's like, well, their blood sugar's normal, they can't have DKA, and you're like, yeah, you do. They do, they have a normal blood sugar, but they have everything else here. They're severely dehydrated, their potassium's way off, which makes all your other electrolytes try to make up for it, on top of giving you a fast heart rate, which is great because now you're tricking your body into it needs to pump faster and harder in order to make up for what's going on. And we're like, no, we don't want to stress out the heart either. So it's a bad circle. Everything has side effects. Literally everything does. So, and the GLP-1s, those have become a problem for the patients. Let's say you need to come in for eye surgery, let's say cataract surgery, okay? Because you're on a GLP-1, if we, for some reason, have to put you under, okay? Have to put you under a general anesthetic. Now we have to worry about the undigested food that's down here from slowing down your digestion. So now they have to say, you're gonna have to hold that med probably for at least a week and let that food get through so we don't have a problem with you possibly vomiting, okay? Once we give you an airway, which always happens when they do surgery, in general anesthetic. So again, everything has a downside. And we don't, Jody's right, we don't know enough about these meds. We haven't studied them long enough. And I sit there and go, yep, on the other side, all the drug companies are saying, what do you mean? The GLP-1s are too normal. They're too normal gut hormones. All we've done is give you more. And we're like, yep, but we don't know what more means. That's the problem. We don't know what all can happen. We've seen it now. The docs have started to write articles about it going, wow, okay, we've got to hold it at least a week. Let's see, our GI doctors are telling us you probably have maybe 2 or 3 days worth of undigested food right now in your gut because the diabetic, it slows down that whole gut. Remember the gastroparesis I told you was a complication? It slows it down. So now add on a med that slows it more. It's doing a beautiful job on your blood sugar, but it's slowing stuff down even more. So, yeah, it is. Lots of debate in the diabetes community. I'm just saying, we used to talk about it almost daily, and then we get a hold of our anesthesia colleagues and say, what are we going to do about it? What do you want to do about it? And they're like, well, let's go with at least a week. We hold those meds at least a week. And endocrinology is like, okay, so what does that do to their blood sugar? Because I don't want their blood sugar to be sky high by the time they get into surgery either. It's manageable, absolutely. If you come in with high blood sugar, they're going to go ahead and, especially for a type 1, they're going to put you on an insulin drip during surgery. They're going to stabilize you and get you under control because that's the best way for you to heal. You need a normal blood sugar in order to heal. So, yeah, it's like I said, this is a huge subject. We could probably talk all day just on hypoglycemia all by itself.
So on type 2 diabetes, that's curable, right? I mean, is that the goal when you go in? Do they work?
No, you are limiting the complications that happen from it. It is a chronic disease.
So there's never getting away with it when the numbers go back to normal?
Nope, you're just gonna get it under control and then live with it.
And no hope of ever getting off the meds?
Well, you can get probably on less meds or go back to diet only, but you're always gonna be diabetic.
Okay.
Yep, the diabetes doesn't go away. It just becomes more manageable. And like I said, I don't have the data on that one as far as the numbers either, but I do know when I was working in the hospital that we had a ton of patients that were diet only, which was a wonderful thing. And they were very, very careful about what they picked. They knew they were diabetic. Here's all the stuff I need to do in order to not let it get out of control, to do more damage. I'm gonna keep an eye on my feet, my eyes. I'm gonna make sure my kidneys are healthy. I'm gonna make sure that I have I'm gonna try to reduce the incidence of a heart attack and a stroke.
since we have a little time here, could you talk about diet a little bit? Because I've been diabetic for about 5 or 6 years, I think, and I'm on metformin, and that's the only thing. I mean, I try to exercise, I try to eat right, but I did see a dietitian once, but she really wasn't very helpful. Can you just talk for a few minutes about what, I mean, I know I gotta watch carbs and sugar, but can you give me some other dietary suggestions?
Well, I tell you, the dietitians, you know, they can give handouts, which is, I know that they did to another member out here in the thing, and she says, and I didn't understand it. And I said, I get it because it's a blank statement. Well, not blank, it's overreaching. Everybody's individual in their diabetes, that's the key right there. What works for you is not gonna work for her, okay? So, as long as, if you wanna do carb counting, I truly love the idea. It's a lot to learn, but once you get it down, it's wonderful because it helps you a lot. It reminds me of Weight Watchers. I mean, it really does, because Weight Watchers works if people stick to it. Carb counting works beautifully if people can go ahead and learn it, and then go ahead and say, oh, okay, yep, I've already gotten to this this carb counting. Of course, that's mostly for the diabetic that is insulin, that's taking insulin. The metformin is a different story.
Just push the button till it's down here.
Just one.
It might have to move it.
So just one question about with the carb counting. Have you ever seen look like when you weigh your food? Because sometimes I think we don't realize every vegetable is slightly different, right, for a serving sometimes. But sometimes it's a lot more food than you realize, and you probably get fuller, and encouraging that. So I was just wondering if you had any thoughts or tips on that.
Oh, yeah, I like that idea, especially when it comes to the proteins. You know, because when you look at any good diabetic diet, they're gonna tell you to limit proteins too, because proteins are hard on your kidney. So if diabetes is doing any kind of damage to your kidneys, you won't be able to manage that level of protein. So I sit there and go, weighing is a great idea, because what I think 4 ounces of chicken looks like, or 4 ounces of beef, is totally different from what it looks like when you put it on a scale and you're like, wow, okay, hope it's filling. Because weighing is a huge thing. I don't think a lot of people do it though. I mean, it was very rare that I would talk to a patient that they'd say, oh yeah, I go ahead and I weigh anything.
Back in Weight Watcher days.
Only people on Weight Watchers and in heart failure.
Yeah, and I know that's when I weigh my food, that's when I have the best luck of keeping my weight under control, because sometimes, like chicken for one, I was not eating near what I thought was one serving. When I actually weighed it out, I was like, oh, this is actually filling. And it's different. So if you want to splurge and have like a steak or something, you can. You just weigh it, right? And then you just know it's not going to be quite as much as if you had a chicken breast, but at least you're not starving yourself. And then vegetables, I was really amazed at how much, especially when you're eating a salad or like celery, like some things you can have a way more than you even thought. But the one thing I thought, I don't even know if I can eat this all.
Yeah, oh yeah, and that's exactly what I used to hear. Well, that's way too much, and I'm like, yeah, but that, when you weigh it and look at the calorie count, that's one serving. So that's why they say, go ahead and pack up that snack and make it veggies. Make it all of those veggies and you can eat that all day, and you're satisfying your brain. Your brain is saying you're eating something, you're munching, that's a use of your energy, okay? And then you balance it with that protein. Like I said, chicken's a wonderful one, and you can eat a lot of it, and it's filling.
Or even like, you're seeing a lot more people eat ground turkey and ground chicken and making recipes, and then you get more too.
Right. And you have to be careful there, because everybody wants to throw on a sauce or a seasoning. And again, remember, you're looking at preventing complications, and one of those complications is heart. So we're going to be looking at that sodium content, which is huge. We had a really long discussion earlier about how the cheap foods, that when you don't have a big budget for good food, the processed stuff comes cheap. And OMG, it's, 10 grams of sodium. And yeah, it lasts forever and it's gonna be dirt cheap, but it's horrible for your body. Horrible for your heart. You're not helping out your diabetes because it's gonna attack your heart and your kidneys. And yeah, I just sit there and go, it's so easy to go with, yeah, I've got a budget though, so how do I do that? We were talking about how, and not that I'm pushing Aldi's, but Aldi's
Well, yeah, I was
is
gonna,
wonderful.
yeah,
But you have to go frequently because their stuff is right on the edge of ripe. You know what I'm saying? But that's why they can give it to you cheaper, because they're not getting it in early. They're getting it in when it's right, you gotta eat it tomorrow. But it's wonderful, it's cheap, and it's what your diet should be. It's fresh fruits and vegetables. We talked about being organic too. Organic usually costs more. So just get it fresh.
2 things, 2 points about that. We had a dietitian that would always tell people that the most valuable way to shop is the periphery of the supermarket. Because all the healthy, fresh things are on the edge, where you get all the processed things in the aisles. And as you said, people worry about the cost more. So thankfully, places like Aldi's have sprouted up where people can get healthy foods.
And we used to have a ton of questions about fast food places in the hospital too. And I said, all of those places have websites where you can actually get it up on your phone and say, I'm having a taco at Taco John's. How many carbs is that? How much protein? How much sodium? So again, if you're carb counting, there it is. It's right in front of you, no matter what you're picking up. Because we needed those. I think all of those, whether it's a restaurant or fast food, all of those places realized that us as providers, caregivers, etc., we were all wondering, hey, you know what, people don't want to eat hospital food when they're here for 3 weeks. You know what I'm saying? So their family is bringing in stuff, and I have no idea about the calorie count. I don't know what carbs, and we're guessing, which is kind of scary. Because if you're acutely ill, if you've ever been acutely ill and diabetic, you know that when you go in the hospital, even though you weren't on insulin at home, that's what they're going to use to get you under control, and then you're going to go back to your regular regime. And everybody always says that, oh, I don't take insulin. And we're like, yep, we need the acute illness under control first, and then we're going to go back to your metformin or whatever, food control.
Okay, so carb counting, do I go online and find, what's the best way to do that?
Oh, absolutely. Carb counting, I see.
Is there a good app?
Do you go to the clinic for, because I don't know anything about Olmsted Medical, but I know that the clinic.
My primary is at Mayo.
Okay. You could actually make an appointment with one of the diabetes educators and they can help you through that. Because I think there's still 8 that work there. They're wonderful. They are diabetes educators. Most of them are certified, and that's what they do all day. They talk to our diabetics. They help them with all of that stuff.
Is that Julie Probach still?
Pardon?
Julie Probach, is she one of the, she's one of our RNs.
Wonderful. Yeah, she's an MP. Yep.
Yeah.
Julie, and then Julie has a lot more to do with that group of the diabetes educators. And if it's inpatient, then I always used to talk to Heidi Click.
So back to diet, keto. I mean, I know you said something about too much protein, but is that, I mean, that's really, really popular right now.
Yeah. See, and keto is horrible for a diabetic.
Oh, okay.
If you look at what the American Diabetes Association says on it, they're like, Okay, I get it, but in somebody who is totally healthy, no underlying disease, your body can handle that protein. It's the direct opposite of somebody saying you can't eat carbs ever again. Okay, that would never fly either, because your body has to have glucose. You have to eat because your liver, that's what it does. It's gonna go ahead and store what you eat, the excess stuff, for later when you aren't eating, when you're sleeping. It's keeping your blood sugar nice and steady.
They like you to get into ketosis or whatever.
Yeah.
Oh,
And oh my gosh, yeah, you don't want that, because then your body starts eating muscle. And muscle, we already have a problem with. As we age, we lose muscle. So, yeah, let's not do that either. It's a balancing act. Like I said, we can talk all day about every single diet and everything that has to be with diabetes. I remember one time I asked one of my colleagues the ICU wants an hour talk on, whatever it was. I think it was ketoacidosis. And she looked at me and kind of like, an hour? No, that's not gonna work. We can't narrow that down. It's huge because everybody is different and our treatment is gonna be different according to what they come in with. So
So I was just wondering if you had an app that you know works really well that you guys recommended
for what? Are we
for
talking
carb
about
counting?
carb counting? I would go through the ADA. Go to the ADA. In fact, they just came out with new guidelines. 2026 guidelines were out last month. I was looking at them going, yeah, they're getting tighter. And again, remember, these are a whole panel of experts from all over the world that get together at a conference and they make new guidelines. And they have different opinions too, and their opinion changes over time. About 6 years ago, they told us, okay, we want you to go ahead and make sure that patients never go low. Okay, we want you to start telling patients, if you have one of those little machines on you, we want you to tell them to set their alarm on that machine at like above 90, maybe 95, 90, okay? Because we never want them to go below 90, and if they do go 90 or below, we want them to start eating, okay? They changed that again in these new guidelines, and I'm like, we just have to keep up. And I love it that they're always doing research and they're always putting stuff in saying, oh yeah, don't do this now. But at least they're doing that research and they're informing us because they know diabetes is a chronic disease and it is not going away. It's right underneath heart disease. It's not going anywhere. It just has to be managed. So.
And just a couple comments that I have found helpful over time. The government has the rate your plate. And it's just a picture of a plate. And for people who aren't quite into carb counting, they envision their steak or their chicken covering 2/3 of the plate, but just that visual helps people.
Yes.
And we had a dietitian speak earlier this year and gave everybody a handout with rate your plate, but it also, as we said, was pretty comprehensive.
And that's been around for a long time, that picture.
And even that's
Because here's your carbs, so mashed potatoes, whatever you want down here, pasta, and then a big third, at least a third should be veggies, over here should be fruits, and then maybe throw in a grain.
We actually have started using luncheon plates instead of
There you go.
regular plates for meals because it makes us eat less.
Yep,
Great idea.
and it divides it up, so then it's a visual again, just like that picture that's been out for, like I said, that's been out for many years.
And another thing that when you were talking earlier, for a few years, McDonald's became a champion with the Heart Association because they started creating healthier foods, and they had
They put out the salads.
and that's when they started the salads and the yogurts. Well, then along came COVID, and so they weren't making the salads. They didn't want people's hands and things, and they've never gone back to that. I think they still have the yogurt parfaits. But you can take anything if used in moderation and make it healthier for sure. But people just think all or nothing so many times,
It's hard. Like I said, I struggle with that every time I go shopping, and I'm like, okay, I want that amount of protein, but I don't want too much. And back to Aldi's. So I'm very biased. Aldi's has a yogurt that's called Super Zero, and it's I think 15 grams of protein with no sugar. It's a Greek yogurt with no sugar.
It's Hy-Vee in a lot of the grocery stores. It's I can't think, not Okios, but
I think that's like 10 or 12 grams of protein.
yes, this is 15, my God.
Yep. And like I said, I mean, if you already have kidney damage, if you already have renal, any kind of renal insufficiency, you're going to be really aware of protein content. But if you aren't and you just want a healthy diet, that's wonderful. So it's, like I said, and it tastes good. That's hard to find.
Not to get into individual foods, but I came upon something. My daughter's pretty health focused, and she found this Fairlight. I think I'm saying it right. The Fairlight, and
That's high in protein too.
Fairlight. Is
Fairlight.
it 15? Now I'm forgetting. I haven't had it for a couple months. But you buy a case of it at Costco or wherever, and it's, what is it, 15 or 20 grams of protein?
I think it might be 25.
It is. It's
It's
high.
very high.
There is a high, there's two different ones, there's a regular one that's probably got more, and then there's one that's higher. But you could also buy milk, it's not a gallon, it's not a full gallon of milk, that has a higher protein, and you can get skim, 1%, 2% whole milk in the Fairlife, in a lot of the grocery stores, and that has more protein. And the nice thing about it, if you're not a huge milk drinker, it lasts longer. The expirations date are, so they go out longer, all of that. So
Yeah.
it's
I
another-
had the
Just
Fairlight
like
in the
almond
fridge for
milk
several
and
months.
soy,
Yeah.
all of that stuff, the expiration date on it is like 2 months.
Plus, it tastes like a chocolate shake. We were talking earlier about what's tasty. And I wasn't really into chocolate shakes, but it really fills you up in the morning. If I have one of those in the morning, I can go till lunch. And it has other nutrients.
Yeah.
I mean, protein's the main thing, but there's other good nutritious things
So it
in it.
satisfies that craving that you have.
It's
It's a drink.
It's a drink, and I think you get 24. I mean, it's not cheap. I don't remember now. I'm sorry. About, what is it? Less than $1 a bottle, but it's a good size. You drink it in the morning, and not that you should, replace other healthy things. But if you're on the go, it's a great snack because it gives you a lot of good nutrition.
And like you said, it goes ahead, and if you get the chocolate ones,
Yeah,
it
I haven't tried it
fulfills that need for chocolate, which is what you were talking about earlier with the Dove, the Dove candies.
So it's called Fairlife?
Fairlife.
Okay,
Yeah.
okay.
I've never heard of it.
42 grams, like the Core Power one has 42 grams.
Yeah.
My biggest struggle is in the morning finding something with protein that I've never been a good breakfast eater, and for a few years I had oatmeal, but now I'm so sick of oatmeal that I'm like trying to come up with something else.
And then have fruit or something on the side with it.
Sure,
Because you're getting your protein, but it's filling. You're not hungry.
How about those overnight oats, because I think like something because then you have a little bit, you have like the milk, some kind of milk in there, but then you might have yogurt and some fruit in there too, and that they tell you to add like flaxseed and chia.
Yes, my
Like some of
husband
that.
does that every day, but
You can't, that's
I
not your
haven't-
thing.
no.
Yeah.
Yeah, because that stuff is really filling.
Yeah.
We're tricking our body, you know.
Good suggestions. And
Yeah.
I had one question that goes back to sort of in the beginning when we were talking about the GLP-1 and 2 meds. I don't know if this is a fair question, but what percentage of people, I've talked to 2 people from within our congregation that are taking them, and one is taking them indefinitely, and another one said they can, only be on it for about, I think, 8 or 9 months. In your experience, Pam, what seems to be the general information given? I've not ever heard of any GLP-1s or 2s that you can stay on indefinitely, safely.
It depends on what you're using it for. You know, like I said, if you're using it only for weight loss meds, or are you
And I'm
using
sorry,
it
that's
for
what they
those?
were using it for, but
Yep.
go ahead.
The weight loss med, I mean, everybody will tell you that's a long-term thing. That's gonna be forever. And they said the people that go off it, they gain back slowly, but they usually gain back a lot of the weight that they lost because they've slowed stuff down. So I sit there and go, but they have wonderful side effects, which is why all of the docs are pushing it for the diabetics. They're like, okay, you saw that macrovascular stuff is hitting your heart and your kidneys. We're gonna help that out. And I told you how it's helping. It is. All of the studies before those drugs came out, it says we're helping the heart failure patients. We're helping the kidney disease patients. And we're like, yep, that sounds good. And that is the reason that the ADA says add it to that diabetics regime. We now have a mandate that when we see our diabetics in the hospital, that we have to go ahead and have someone come and talk to them about, I see that you're not on a GLP-1 or SGLT2. You might benefit from that. And then they leave it up to their general practitioner at home to decide do they go on it or not, because it needs monitoring.
But isn't it also extremely expensive still?
Oh, yes.
Like $1,200
Yes, they are.
a month?
Yep.
Yeah.
Yeah.
I
But I
know
mean,
we're
the
seeing,
side effects of them are
we're seeing more, what I've just heard in the last few weeks that they're attributing to some of those GLP-1s is pancreatitis.
Oh, absolutely. And I've seen that multiple times. And I sit there and go, just another reason not to be on it. And they're like, yeah, but I lost weight. And I'm like, yeah, but you're setting yourself up, because once you have pancreatitis, you are going to have it again. It is going to happen again. It might not be as severe, but now you are in the category of chronic pancreatitis. All you probably have to do is, and that pancreas is such a finicky thing. I mean, we see it in the end whenever they go in, like if they have to do surgery on it, they say the tissue to it is like friable. I mean, it's a delicate organ I don't want to fool with. So if I know that pancreatitis could happen, I never go on it.
And I know my sister is a pacemaker nurse, and they started to see a lot more cardiac, especially with these young ones, like very, risky cardiac complications.
And like I said, you have to remember how they work. You have to be very well informed on how that's how they work. They go ahead and they take the glucose, dump it in the urine, and out it goes. Well, what is it carrying? It's carrying your potassium that you needed for a good heart. It's carrying a ton of fluid that you need hydration, otherwise things shut down. It does damage. And then we have to go in and correct it. You know what I'm saying? We dump a ton of fluid on somebody that might even have already heart failure or heart problems. Maybe kidneys don't work like they should. Now you've got another problem. So.
One more comment about that is that, I think we had a cardiac colleague, a nurse, who went on fen-phen. That's been years ago when it came out. And she went into heart failure, a young woman, and it wasn't reversible. She needed a transplant.
Right.
And those are the kind of things that the jury just isn't out, on all of this, because we just don't know.
Yeah.
I mean, totally separate from this, but e-cigarettes is a good example.
Absolutely.
People think, oh, that's so much better. We don't have a clue what that's going to do long term.
Gosh, well, and now we're starting to see it. They show pictures. This is what vaping does, and this is what smoking would have done. Totally different.
Yep.
They look totally different, and you're like, oh yeah, but you don't have the smoke in the air, and you're like, actually you do. You just don't see it. You know what I'm saying? People around you are still inhaling, because where do you think the vape goes?
Yeah.
So.
Well, I think people don't realize because you don't have the smell, right? Like
Correct.
you could smell cigarette smoke, you don't smell it smells, or if you do smell it, it's more fruity, or that, so you don't recognize it as a smoke smell.
Yep, and
But it's still
that's
not
how they're.
good for you.
That's how those companies were hooking kids. They were putting it flavored, different flavors. Kids were like, oh, this tastes good. So, yeah.
Wow, good information. Any more questions? This has been wonderful, Pam. Thank
Well,
you.
like I said, I did put my
I love your email.
address, yeah. So feel free to email me if you have more questions. If I don't know it, just like in the hospital, if I didn't know the answer, I had a boatload of other people that I could ask, because no one person can know everything. So I'd be happy to help or try to guide you.
Well, you may get more questions because, again, this goes, we're too close. This goes on our Redeemer website, and then, people, then they have questions. So we'll have you come back again.
Oh, sure. Certainly.
It's wonderful. Well, just a couple of comments. I laid my phone down somewhere, and I'm not sure. I thought I left it up here by you. There it is. But I was going to look. Our next Caring Connection meeting will be in February. I need to look. The second Monday in February, and that would be the 9th, correct? And I don't have an exact title yet, but we have a gentleman who actually works for the Visiting Angels Corporation, who is gonna come and talk about decision-making as we age. You know, whether it be housing, questions that people have, because he's branched out from working with the Visiting Angels, or in doing that, to help people find resources. So we're looking forward to have him, and then in March, we're gonna have the same gentleman and another man talk a little bit about, resources in the Rochester area. So a couple of good topics coming up, so. Again, we thank Pam Grubbs. This has been a wonderful presentation and so much food for thought. And with that, should we just end with the Lord's Prayer? We'll end with the Lord's Prayer. Our Father, who art in heaven, hallowed be thy name. Thy kingdom come, thy will be done, on earth as it is in heaven. Give us this day our daily bread, and forgive us our trespasses, as we forgive those who trespass against us. And lead us not into temptation, but deliver us from evil. For thine is the kingdom, and the power, and the glory, forever and ever. Amen. Thank you all so much for coming. Thank you.